afternoon, and good evening to all our speakers, chairs, and the wonderful audiences in different parts of the world. Welcome back to ACNS webinars. The speaker for the first session of today is our honorable guest from India, Professor Krish Sridhar. Professor Sridhar is the Director and Group Head, Institute of Neurosciences and Spinal Disorders, and is Chief of Neurosurgery and Spine Surgery at the MGM Healthcare, Chennai. He is the current Honorary Secretary of the Neurological Society of India, and he is also an adjunct professor at the TN Dr. MGR Medical University, Chennai. He has several publications and international and national peer-reviewed journals, and has edited the textbook of neurosurgery and operative neurosurgery, and he has contributed to several chapters in various other neurosurgical books. He has traveled extensively, delivering lectures on his areas of expertise, and includes cervical spine, skull-based vascular neurosurgery, and neuro-oncology. He has been a member of the executive board and the council of several societies, including the Neurological Society of India, Indian Society of Neuro-Oncology, Skull-Based Surgery Society of India, and Association of Spine Surgeons of India. He has been the organizing secretary of the annual conference of the NSI in Chennai in 2016, and the president of the first virtual conference of the ACNS in December 2020. We are extremely honored to have him today at webinars, and today he'll be talking about neurosurgery, the agony, and the ecstasy. The speaker for the second session of today is our honored guest from China, Professor Wang Enmin. He is the professor and vice director of Cyberknife Center at the Department of Neurosurgery, Huashan Hospital, Fudan University, Shanghai. He is a board member of the International Stereotactic Radiosurgery Society and the American Society of Clinical Oncology. He has received several awards and honors for his outstanding contribution to neurosurgery, and is also a noted author with several publications in various peer-reviewed journals. We are extremely honored to have him today at our webinars, and today he will be talking about Cyberknife radiosurgery for brainstem lesions. The chair for the first session of today's webinar is our honored guest from Saudi Arabia, Professor Imad Kannan. Professor Kannan is a senior consultant neurosurgeon at the King Faisal Hospital and Research Center, Saudi Arabia. He is also the president of the International Society of Neuroanatomy. He was the past chair of the Neuroanatomy Committee of the WFNS. He is vastly experienced neurosurgeon with several publications in various peer-reviewed journals, and he has contributed greatly towards the neurosurgical education for the young neurosurgeons by conducting several online webinars during the last several years. We are extremely grateful to him for accepting our invitation to chair the first session of today's webinar. The chair for the second session of today's webinar is our honorable guest from Pakistan, Professor Syed Athar Inam. Professor Inam is the professor of neurosurgery and chairperson of Department of Surgery at the Aga Khan University Hospital, Karachi, Pakistan. He joined the AKU as an associate professor and developed the state-of-art neurosurgery program there, and has trained several generations of young neurosurgeons. He is a recipient of several awards and honors, including the Excellence Award in Neurosurgery by Pakistan Society of Neurosurgery, as well as the prestigious Sitara Imtiaz Award, highest civilian award by the government of Pakistan. He is a life member of the Sigma C and the Scientific Research Honor Society, as well as founding president of the Pakistan Society of Basic and Applied Neurosciences, the Pakistan Society of Neuro-Oncology and Neurological Surgery. We are extremely grateful to him for accepting our invitation to chair the second session of today's webinar. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to welcome both the speakers and chairs to this online podium of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely grateful to Professor Shubin for broadcasting this webinar on the WeChat channel. With that introduction, I would like to hand over this online podium to our first chair, Professor Imad Kannan.
Yeah, well, thank you very much, Professor Raja, for the invitation, and to you and Professor Kato. I am to join this fine group, Professor Inam and Professor Sridhar from India, and a colleague, I think, from China or Japan. Bottom line, I like the title. The title, fantastic, Professor Sridhar has selected, is a common title, is a translation from the famous novel written by Irving Stone many years ago, and I watched a movie made after that by Charlton Heston. Yeah. I didn't like Charlton Heston as an actor, but I liked the co-actor Rick Harrison, because he was filming in Compact, which we used to see as a child every week on Cadua. Novel reflects actually the challenges and hard work of an artist to fulfill to him by the pop. He found for the to paint on that ceiling is not give it away. He has to accept it because of the peer pressure. Raphael, who's an artist too, was the next candidate to have this task, accepted the task, and he suffered by putting a lot of effort. Sometimes it's the historical war to take Florence from Rome, stopped that project for many years. So it went up and down, but eventually the achievement and the joy was what he achieved. And this is reflected of the ecstasy that he could get. And I'm sure that title was used by many, not only neurosurgeons, by psychiatrists as well. There is even a medication for that, ecstasy. Yeah. And they have studied the amygdala and positive and negative responses. And I'm very keen to hear Professor Krishna to reflect on his neurosurgical aspect. We are not different. We are an artist after all in our practice, and I'm sure you will enrich us with the information. Professor Krishna.
Thank you very much, Professor Imad. So I shall begin by giving my salutations to the founder member of the Neurological Society of India, Professor V. Ramamurthy. This is his centenary birth anniversary, and he has been a large figure even in the foundation and the early years of the ACNS, along with Professor Kano, Professor Kato, Professor Raja from Pakistan, and others in the area. This is 1993, where Professor Kano had this brilliant idea that neurosurgery update for young neurosurgeons in Asia, and I was there as one of the lucky recipients of this, where we learned a lot on current state neurosurgery in Asia, and that has now transformed into what we know as the ACNS. This was in 2004 with Professor Kano and Professor Kato, and my knowing Professor Kato and friendship with her has grown over the years when we have visited different places, and she has come to India for many conferences. So thank you, Professor Kato, for having me on this webinar to give this talk. Very important that in 2016, the Women in Neurosurgery India, which was very close to Professor Kato, was inaugurated by her and Professor Kanaka, who's seen here in this photograph. Professor Kanaka happens to be the first woman neurosurgeon of Asia, and her birthday from 2022 is being declared as the Women in Neurosurgery Day by us at the Neurological Society of India. So we celebrate the women in neurosurgery on 30th March every year. We also had the opportunity of hosting the Asian Congress of Neuronursing in 2020 January. We had over 250 neuro nurses come to Chennai to our hospital, and we had a great time listening to them and looking at all their problems, their strengths, and their education. I also had the opportunity, thanks again to Professor Kato and the ACNS board, of hosting the virtual international conference during the COVID in December 2020, and this was immensely successful conference. We also had the ACNN at the same time, and I would like to thank everyone across the world for their support and cooperation in this. So coming to the topic, neurosurgery, the agony and the ecstasy. I'm from Chennai, which is in the south of India. I also happen to be the Honorary Secretary of the Neurological Society of India. And like Professor Imad Kanan said, the title is from this book, The Agony and the Ecstasy, which outlines the life story and the struggles and the triumphs of Michelangelo. Now, we all see the beautiful works that have been done by Michelangelo all across the world. We know about him. In India, especially in the southern part of India, we have these gorgeous temples which have been built. This particular one is the biggest.
Having some gaps, no voice could hear from you, Dr. Sridhar.
You can't hear me?
Well, we can hear it well, Professor Imad. It's working well.
Yeah.
Okay, so this is the world's perhaps second largest bas relief. The question is, this this means when you do work like this, it is like walking on a tightrope. And this was a favorite photograph of Professor Ramamurthy, which he brought back from France during his travels, and which he used to keep saying outlines what a neurosurgeon's life is. And a neurosurgeon is one who cannot afford to make a mistake. Because once you make a mistake, you either spoil the artwork or spoil the stone or the patient's life. So neurosurgery is not only a science, but like Professor Imad Khan very rightly said, is also an art form. And though compared to decades ago, times have changed and mortality, morbidity has drastically reduced. And this has led to an evolution of aims and goals in neurosurgery. And what has changed is that our aims and goals have changed from saving the life of the patient to saving the patient functionally. And I think this is a very, very important thing that we need to understand as neurosurgeons, that we need to save the functional patient rather than just the life of the patient. And the reason why we have evolved is because of advances in technology. There have been advances in radiology and diagnostics, very importantly in anesthesia and monitoring, including in the post-operative period in the intensive care, and very important improved technology in the OR with improved instrumentation. The OR and the ICU are like labs where we have so much of instrumentation. We can really do a lot nowadays with the technology that we have. And what has happened over a period of time is that from saving lives, reducing mortality, morbidity, came a time of extreme technology revolution. And then we have been able to cure and perform complex procedures. And this is also important to understand that this is not only because of the neurosurgeon, but because of a combination and interaction of various disciplines across neurosciences. It cannot be only one department or one neurosurgeon doing this, but it's a teamwork across neurology, neurointervention, neuroradiology, neuroanesthesia, and critical care, most important, nursing and rehabilitation. And this is why I have, in the last decade or so, been talking about the concept of integrated neurocare, which is so important to achieve quality life for patients in neurosurgery. The ecstasy of modern neurosurgery is that we can reach anywhere in the brain. There is very little that we can say we cannot reach that place in neurosurgery. And one of the most important advances has been the endoscope for endoscopic third ventriculostomy, and where you can do away with the shunt procedure. And this is from starting with obstructive hydrocephalus. Now the indications have gone on to even sometimes meningitis, tuberculous meningitis, post-hemorrhagic hydrocephalus, and other indications as well. Not only that, the colloid cyst, which is almost situated right at the center of the brain, can be approached quite significantly and quite easily. And I prefer to do the interhemispheric transforaminal approach, where you can quite easily, just through a small opening in the corpus callosum, remove the colloid cyst, and the patient is technically cured for life. This is an example of a large tumor extending right from the lateral ventricle, right down almost to the floor of the third ventricle, a 6-year-old girl with raised intracranial pressure. And this was also approached through the interhemispheric approach. And that is on the 4th or 5th day post-operative. You can see the girl is absolutely fine. The girl was from Iraq, and when I visited her, and that was a couple of years later, and she's doing fine. The point being that this is what is the ecstasy of neurosurgery. Another, when you see children like this, a child presenting with no appetite and failure to thrive, points to a lesion in the hypothalamus. And this, like you can see, is a cystic, multicystic lobulated craniopharyngioma located right at the base of the brain. I prefer the transcranial approach to these lesions. I do not do the transbasal. So we go pterional, lateral subfrontal, and then remove the tumor, as in this case. So as we can see here now, we debulk the tumor, we empty the contents, and then start the dissection of the tumor from the opposite optic nerve, and making sure that we stay onto the arachnoid planes. Now, that is for me the most important thing. Tissue handling and respect for the arachnoid planes is something which has to be learned and has to be looked for every time. We have to be careful about that. Tissue handling, like we said, it's an art form, neurosurgery, and we have to treat it like an art form. The movements of the micro instruments and other instruments has to be like a painter's brush. It has to be delicate, and it should not be, and it should be something which should be easy on the eye. It should not be like as though, you know, you're butchering something, to be very crudely said. And this is at the end of surgery. The child has done well, and this is from 2013. The child was operated. This is last year when we had a brain tumor support group function. The ecstasy is that we can do large basal tumors like this, even in a patient who has got other problems like hemophilia. And this we operated in 2007, and the patient has died doing well without a recurrence. So these are things which are possible because of current modern day neurosurgery. The other aspect which has now improved grossly is microsurgery for gliomas. Tumor fluorescence, DTI and fMRI, intraoperative neuromonitoring, intraoperative ultrasound more than intraoperative MRI allows us to radically remove tumors. As we know that the more we remove a tumor, the better is the prognosis. So that's what we do when we can use all this technology. For example, a 45-year-old lady with a right parietal lesion like this, you see the tumor there, and using fluorescence, you can see where the tumor is left behind. We do not have 5-ALA. We use the yellow fluorescence, and this is how we can remove a tumor as radically as is possible. Now, concepts have changed in understanding the brain as well. And this has been due to development and research and science. And we now know that what we thought were specific eloquent areas in the brain is not so much just restricted to those areas, but is actually, it is a more widespread function. The function of the brain is not limited to certain areas, and there is no area of the brain that we can actually say is non-functional or non-important, because we now know that the brain works through networks, and it is important that when you operate on the brain, whether it's a glioma or anything else, we understand the concept of these networks. An example is that when we look at emotion, it is not just one part, or it's not just the frontal basal part, but it's an entire circuit that we are looking at. If we look at speech, it is not just the Broca's or the Wernicke's areas, but the entire circuit, because you may not be operating, or you may not be taking a tumor out of the Broca's or the Wernicke's area, but if you handle the circuit and if you destroy fibers which connect the network, then you would be causing a speech problem. And that is very, very important to understand. And for example, number processing. Now, you would have to ensure that the entire network for number processing is preserved in a patient, for example, who is an accountant. And these are the important aspects of function which we need to look at nowadays when we look at a patient with a glioma or any other intracerebral problem. And the importance of networks is now becoming more and more emphasized in all work. And that's where the concept of looking for the diffusion tensor imaging comes in, because we can look at fiber tract anatomy as good as the anatomy textbooks. And that is possible now. And the usefulness of DTI in intraaxial tumors is that we know we can decide the route of approach so that we disturb the fiber tracts less and less. We can prognosticate, and we can even decide on the extent of excision. And lesional factors sometimes help in prognostication. There are 4 abnormal tract patterns of tract involvement seen on DTI. The tracts can either just be displaced, they may be infiltrated, it may be edematous, or it may be destroyed. So one of these 4, and how we know these is not only looking at the tractography, but also measuring the FA values, where we can actually have a quantitative valuation of the FA of the tracts, then so that we can say what is happening to the tract. So planning of surgical approach, a very classic example, a 35-year-old lady with focal seizures, right parietal lesion adjacent to the medial cortical surface. What we would normally think is that we would go approach straight away like this through the interhemispheric approach here. But my problem was that these fibers were coming over the surface, and I did not want to cause any sort of traction injury or retraction injury coming here. And therefore, we decided in this patient to do a navigation-assisted contralateral interhemispheric approach, whereby we went across the forks, opened the forks up, and then with the help of navigation, were able to reach the lesion like this and take out the tumor. This way, the surgeon's point of view is in a straight line, and we are not looking over the shoulder of a normal cortical surface. This is the patient did well. Another example is a 35-year-old man, a seemingly simple lesion, large cyst with a mural nodule. But when we did the DTI, we found that the lesion was surrounded on all sides by important tracts. And this is very, very important to understand. Therefore, the only way we could really approach it by causing least disturbance, and this is an article which actually emphasizes what I'm saying, which says that looking at preservation of tract articulate fasciculus and the temporoparietal component of the superior longitudinal fasciculus was statistically correlated to the absence of postoperative language deficit, which means that we need to make sure the articulate fasciculus and the superior longitudinal fasciculate are preserved. Therefore, we went through the Sylvian fissure. Going through the Sylvian fissure, we reached the cyst and we removed the lesion, which was a pilocytic astrocytoma. And 34-month follow-up, the patient is doing still well. So the same DTI is now, when you look at the brainstem, I think it is very, very useful to understand whether the lesion is circumscribed or infiltrative, because you can actually look at the infiltration of the fiber tract and decide whether a particular lesion is okay for surgery or not. We also now understand more and more the anatomy of the brainstem, and there are multiple safe entry zones for brainstem lesions that have been described. We also now understand the most important thing in the brainstem, which is the respiratory centers and the physiology of respiration, starting from the pneumotaxic center, which inhibits the apneustic center, and where you have the dorsal and ventral respiratory group of nuclei on the right on the floor of the fourth ventricle. An example of a brainstem multicystic lesion in a 1-year, 3-month boy, multicystic lesion with some blood layering in it. So we went retromastoid in this child, looked at the lesion, aspirated it. It looked like only blood. This is between the 5th and the 7th nerves. And then we peeled off the layer, the very fine cystic lesion of the surface of the brainstem, and then we did as much as we could. We knew we had left a small bit behind. there, and but we could not see it. So we left it behind, but 10 days post-op, the child came back to the ER with the bleed. So we went this time through the brainstem, through the midline approach, and we accessed the hematoma and removed the residual part of the what turned out to be a cavernoma. Now, this is where you sometimes have to be very, very careful. And this is when a small residual part of cystic craniopharyngioma is known to bleed, especially in the first 1 month. And therefore, it is very, very important to plan what you do. Otherwise, it can be an absolute disaster for the patient and for you as well. And the child did well, and now 5 years post-op, though the child has a bit of hemiparesis and a 6th palsy, but the child is doing reasonably well with no recurrence. This was a 3-year-old girl who came to us. Brainstem lesions are something close to my heart. We have now been looking at that for the last 10 years and doing a lot of work with them. And we've looked, sometimes we get lesions like this, which have been termed as a diffuse pontine glioma. But when you look at this lesion, we can see that a lot of the tumor is actually exophytic and coming into the CP angle and the cerebellomedullary cistern. And therefore, we approach this through a cerebellomedullary cistern approach, a lateral approach, and we were able to take this out radically, though it turned out to be an anaplastic grade 3. And so that is the tumor here, and that is the normal cervicomedullary junction. And this has to be removed very, very gently. You would have the lower cranial nerves draped over the lesion, and you would have to work through multiple corridors in front of the lower cranial nerves to remove this, this tumor. That's when we came to this particular tumor, who was an 8-year-old girl, what seemingly looked like a diffuse pontine glioma. And as usual, we did the DTI. This is a normal DTI for reference with the corticospinal tract, transverse pontine fibers, and the medial lemniscus. And in this girl, what we found was the entire thing was shifted backwards. We looked at the FA values, and we found that majority were only displaced and few were edematous. We look at it being destroyed if it is more than 30% reduction in the FA value. And looking at the tractography, you can make sure, except for a few fibers of the corticospinal tract here, majority were shifted back. And therefore, we decided that we will go in and operate on this tumor. And using navigation, we did a retromastoid approach and operated on the first postoperative day. Her swallowing improved, and by 3 months, she was good to go with no neurological deficit. She, of course, received radiation and chemotherapy for her tumor, and she's being followed up. And this is what we published as DTI and tractography being a major determinant of resectability, a description of a new subtype. And we feel very strongly about this, that we should operate and give relief and better quality of life to all patients, irrespective of where the tumor is. Ventral lesions in the brainstem are more difficult. Some of them most often approach to some form of pterional approach, but we may have a lateral temporal or basal approach as well. A classic example is a ventrally placed cavernoma like this in the midbrain. So we approach this through a pterional 1.5 approach. We went right to the base. This is the tentorial edge here, which is being looked at, and then we followed the third nerve to the brainstem. This is the third nerve here, which you can see, and then we followed it to the brainstem, going medial to the third nerve and looking for the area. This when we did the surgery, we did not have navigation, so we had to rely on looking for the colored PA, and we found that there. This is the third nerve here. We found that, so we went in and removed. That was the hemorrhage. And once you see the hemorrhage in a cavernoma, the rest of it is follows very simply, and that is the cavernoma coming out. And that was the cavernoma, and that was the patient doing well postoperative. This is a more complex tumor with a midbrain lesion coming out exophytically supracellular, and not only supracellular, but also going into the thalamus as a large cyst. And the problem here was that the entire lesion was behind all the vessels, and perhaps would be draped by the perforators. And therefore, we had a lot of conversation looking at DTI and looking at other things as to how to approach this lesion. And what we did, was a TRIONal approach. We removed the anticranial process. We opened up the sylvian fissure as widely as is possible. So you can see here the carotid, optic nerve, the bifurcation, that's the tentorial edge. That's the PCOM there, that's the anterior choroidal vessels, and that is the tumor peeping out from behind all these. And we keep this cottonoid just to make sure that the heat from the bipolar doesn't go on to the normal vessels. And you take that little bit of window there and start debulking the tumor and keep debulking. And then here you see the inferior arachnoid. You can see there as you remove the tumor. And then medially, you start seeing normal brainstem. And once you start doing that, you remove some more tumor. And this is the midbrain here, you can see, and that's the tumor which has got invaginated into the midbrain. And it seems to have a reasonable plane, if you may, into that. We weren't very aggressive there except to remove what came out. And at the end of the day, we were able to see a lot of the brainstem and structures behind. And then we also opened the lamina terminalis for what it's worth. The post-op MRI showed us that we had removed the tumor radically. This was a grade 2 IDH mutant lesion. We have subjected her to radiation, and she's now undergoing chemotherapy. Functional neurosurgery is something which is very important nowadays with the advance in technology to bringing a patient back to their normal functioning. And most important in this, for me, is epilepsy surgery, especially in children, when structural lesions should be operated upon to control, and non-structural, difficult to control epilepsy needs good evaluation. So you have to approach a surgical option if 2 AEDs in proper dosage does not effectively control seizures. And this was a 14-year-old male who started having seizures and was on all these drugs, but still continued to have seizures. And this was the cause, the opercular cavernoma. And this had to be operated and removed. And now he's doing well. Another child with a Lennox-Gastaut going into the autistic spectrum had developed continuous lesions despite anticonvulsants. And this is the sort of seizure that he had. And you can see how violent it can be, the head drop. Though people would think it is only a head drop, but for a child that would be the lesion. And this is what happens every time the child falls. So he was on sort of a body leash whenever the mother took him out. So we took the EEG. There was background epileptic activity starting from one side and going on to the rest of the brain. And therefore, we did a corpus callosotomy and we attained normal EEG background activity. The child is now free from seizures. So Lennox-Gastaut is something where corpus callosotomy works very well. And this is something which I think should be looked at very, very seriously. The trigeminal neuralgia is something which patients are at real pain, and it's something which you cannot take lightly. And if carbamazepine does not work, I think the concept of Peter Geneta of doing a microvascular decompression should be looked at. There are 3 neurovascular bundles, each with their own syndrome. But the beauty of this surgery is in the arachnoid dissection. of each of these nerves and vessels, because the nerves are normal, the vessels are normal. And what you're doing is dealing with normal anatomy only, which is in abnormal contact. And therefore, it is your job as a fantastic technician, an artist, as a neurosurgeon, to ensure that the patient does not have any post-operative morbidity when you do the surgery. So this is surgery for trigeminal neuralgia. This is a case where you can see the nerve is sort of invaginated by the vessel, and you have to do this in high magnification with an artist's touch. And that is what I would like to emphasize to my younger colleagues. And this does not come overnight. You have to practice under the microscope. And microsurgical workshops are important. You have to practice, practice, practice. And like Professor Yasargal used to say, a concert pianist can never perform just on stage. He would have to practice every day before you can go on stage. And that's also true for a neurosurgeon. Sometimes you would have large petrocell veins, and you cannot just sacrifice the vein. I'm completely against sacrificing the vein. You would have to spend time and effort in skeletonizing the vein and getting to that little bit of space between the veins to make sure that you can actually see the compressing vessel. I am now currently looking at the value of microvascular decompression in tinnitus, and we find that we are getting a good result in about 80% of patients, provided they are selected properly, and we have a very strict protocol. And I think this is a fantastic surgery, microsurgical decompression. The use of the endoscope in this surgery cannot be emphasized because it really helps show us the anatomy very well. Sometimes you get doliectatic vertebrobacillars, especially in hemifacial spasms and sometimes in glossopharyngeals. And then you would have to really understand the anatomy before you can dissect it. And what we did in this case, it was so heavy that we had to do a sling and take the sling carefully, make sure you don't disturb any of the perforators, you don't disturb the internal auditory artery, which is right there. And then you would have to use the sling to make sure that you get the vessel away from the nerve. And that is very, very important. You have to, end of the day, you would have to make sure that the vessel is away from the nerve. And that is perhaps prime in this surgery. Also important when you're doing this is to ensure that, especially when you're doing it in an elderly person, that there are no atheromatous plaques on the vessel which you may disturb, because that can be disastrous if you do that. So you then take a stitch onto the lateral petrous dura and stitch that sling up, and that would give you a really good decompression. The agony now. When you have tumors, meningiomas like this, a petroclival meningioma, operated, grade 2, irradiated, but then they come back, tumor is grown. Look at the edema on the brain stem. Look at the edema across the brain. And there is really nothing much that you can do, can you? It is so tempting to go in and operate, but then we have to remember that we cannot afford to make a mistake. The problem of gliomas is the agony. Yes, we can do fantastic work. Our extent of excision has increased. Our capability of removing tumors with a good functional patient has improved, but they always come back, don't they? And we still have not found the answer for that. Though there are new drugs coming up, the classifications have changed, the IHC and the molecular biology is being understood, but we still do not have an answer for gliomas, wherever they are, whether they are in the brainstem, whether they are in the cerebral hemisphere. We still do not know how to cure these tumors and what to do other than giving a good, proper resection. So when these tumors come back, we don't have very much to offer except for perhaps resection again in certain cases, and perhaps upping the the chemotherapy, which very often does not do much. Sometimes we do have 5 years recurrence-free survivals, but we are always aware that this tumor can come back. Spinal cord injuries, the Superman who went into a wheelchair. We can correct the bony spine, but we really can't do much for the spinal cord. A lot has been tried, but we still have patients who are like this. Rehabilitation is a major part of their treatment, but we are not really able to do anything to repair the spinal cord. Meningomyelocele, what could have been prevented by folic acid? Fetal neurosurgery has come of age. We know that we can reduce the effects of a meningomyelocele you're doing fetal neurosurgery, but that's not the answer. The answer is we need to prevent this, and advocacy for the use of folic acid is very, very important. So, friends, modern day neurosurgery has agony and ecstasy. The ecstasy is that surgery is exciting and developments are exciting. We are now doing what we thought could not be done, going where we thought we could not go, achieving what we thought we could not achieve. But we are still waiting for answers for TBI, for spinal cord injury, congenital defects, and of course, gliomas. But there is hope because there is neuromodulation, neural networking, neural re-education. There's a lot of research work going on in this, and we are still understanding and learning more about the brain and the nervous system. This is a last case I will take you through. A 1.5-year-old child who fell about 14 feet. The child was irritable and crying. The initial CT did not show much except for a thin STH. The child was having seizures, intubated and secured. The CT repeated no change. And then there was no response. And the transcranial Doppler showed high resistance flow, which is almost like a cerebrocirculatory arrest. We repeated the CT, which showed bilateral occipital and cerebellar hemisphere infarcts. We did an emergency EVD and post-fossa decompression. ICP went down to less than 20 with drainage of CSF, and the immediate TCD was also good. But then within a few hours, again, the pupils went up, ICP went up. We did a CT which showed extreme compressed ventricles, diffuse cerebral edema, effaced cisterns, and patient child was on maximum medical treatment. And a 1.5-year-old child, what can you do? And TCD again showed cerebrocirculatory arrest. We told the parents of the extremely bad prognosis, and they wanted us to do whatever they could. And we then did a bifrontal decompressive craniectomy and said this is all that we can do. Then the CSF started draining, the ICP was maintained, repeat TCD became better, and slowly the child improved, extubated on day 25. We then, after 3 months, did cranioplasty, aggressive rehab, and 5 years now, child is going to school. Yes, with a lot of problems, but going to school. And this is where, ladies and gentlemen, there is hope. There is hope that things will become better. There is hope that we can do more for patients. And that is what takes us on every day. Despite all our problems, despite all our agonies, there is ecstasy when we see children like this. There are many lessons to be learned every day. It's up to us to keep learning and keep abreast of new ideas, thoughts, experiences, and developments that can make our lives and the lives of our patients safer and better. So thank you to my patients, thank you to my teachers, and thanks to all of you for your patient listening. Thank you very much.
Thank you very much, Professor Sridhar, for this very comprehensive review of the agonies and the ecstasies. Yeah, you covered most of the aspects of our neurosurgical practice, and with the charming cases, tough cases. We all have the inborn genes to deal with challenging cases. We never report a small convexity meningioma and we achieve a full cure. And this is where the difficulty. But the most important message you have given, and I just want to summarize some of the points, like vascular procedures and vascular decompression. This is a subarachnoidal procedure, not intra-axial procedure. You should not encroach on the brain or the brainstem. The other things, you never make a judgment, the ego never encroach on the outcome of the patient. This is the most important for young generation to know. We all come out, I did the surgery by myself alone, and I did it complete removal. This is not only enough. You have to do this with the guarantee that the patient has no morbidity or mortality added to his clinical condition. If anything, he should be better. And of course, neuroanatomy and microsurgery, these are the essentials. We are not orthodox by learning, and we don't go by authoritative learning, but these are, we over the years found that the most important part is the training in microsurgery. These are essential in all cases you have done with the delicate artistic work on this structure. Thank you again for sharing your experience, and I hope that I'm sure the young generation, they have got a lot of information and enticed to be building up their knowledge in microanatomy and microsurgery. Thank you.
Thank you very much, Professor Imad Kannan and Professor Chris Sridhar. That was a wonderful lecture and such very complicated cases that you have shown. We learned a lot. There is one question that has popped up in the chat box, and it's
Before you go to this question, I just want to concur with Professor Krish about craniopharyngioma. I myself, I still believe the best route is going from above so you can handle your complications. Enough to pull a little bit more and you tear this calcification on a vessel and it will be a catastrophical outcome. And I have seen cases like this, they went through the nose and especially in calcified lesion, okay? Some of the purely cystic lesion they can manage, although the leak side is still an issue. But with calcification, you are better off going through a terminal approach. That's what I like. Lamina terminasa, it depends on the extent of the tumor, and I agree with this completely. Thank you.
Yes, thank you very much for that comment. There is one question from Dr. Harshit Parekh, who's writing, how you, Dr. Sridhar, how you managed
so the
to
ventricle, so the ventricle, when we did the EVD, was not slit. The ventricle at the time of the posterior fossa infarct was dilated, so we were able to cannulate it.
Thank you very much. So I think if there are no further questions, Professor Inam, any questions or comments from you?
No, thank you very much. This was a great lecture by Professor Sridhar. It just sometimes when sometimes the whole life runs right in front of your eyes, and I hope that you're not dying at that point. But this was like that lecture that everything that you've done in your life was right there, showing that these are the good things and these are the things that really give you so much pain. And it connects me to Henry Marsh's book on complications, and that as you grow old, and if you are a good surgeon, and I know Dr. Sridhar for one is a very well-known and compassionate surgeon, all these complications, they stick in your brain. You don't get rid of them, because that makes you humbler and humbler, and that makes you more of a careful neurosurgeon as time passes by. But it does affect your own psyche as well over time. And I think all the neurosurgeons who have experienced so many things, like Professor Kanan, and also these complications, there is no neurosurgeon who does not have any complications. And the more you do, the more complications you have. You just have to get more and more humble. That's all. That's the one lesson that I've learned. Thank you for reinforcing that, Dr. Sridhar.
And now we'll move on to the second session, and I would like to hand over this podium to our second chair, Professor Inam, who would say a short introduction about Cyberknife radiosurgery and invite Professor Enmin for his lecture. Professor Inam, all yours.
Thank you. Thank you, Professor Raja and Professor Kato, for doing this wonderful thing and spreading the knowledge across the world. It's a wonderful task that you guys are doing, and it's really an honor to be a part of this group that you have collected. To be on the same screen as Professor Kanan and Professor Sridhar. My guest is a very well-known and very respectable professor, Professor Enmin Wong. Professor Wong is, if you have gone to the neurosurgery meetings across the world, you have come across his amazing number of cases that he has done for radiosurgery. So Professor Wong was trained in medicine from Henan Medical University. He got his master degree of medicine over there, and then he did his doctoral degree in medical sciences from Shanghai University. He was then trained further in Queen's Square, London, which is the mecca of neurology and neurosurgery. And then he was also a visiting fellow in Pennsylvania University. He then came back to China, and he was further trained in Department of Neurology at the Henan Medical University, from where he moved to a very large hospital with a very high volume of surgical cases in Shanghai. That's the Huashan Hospital. And Huashan Hospital, if you guys know, is one of the couple of top, best, and high volume hospitals across the world, actually. And that's why Professor Wong has such a high experience in these radiosurgery cases. And this area of what he's going to talk about is probably an experience that very few of us across the world would have, because again, the volume is very high in Huashan University. Professor Inman has received several grants, and he has received several awards in his process of becoming more and more expert. The topic of the radiosurgery for brainstem lesions is something that we all are holding our breath to really figure out what is the right thing to do. You just saw Dr. Sridhar talked about the surgery for the brainstem lesion, but then most of the brainstem lesions we are very afraid to touch, and we see those patients end up in dying and in severe problems. So, Professor Enman, please enlighten us with your experience, with your vast experience. Thank you.
Thank you, Professor Said, and element introduction. Good evening, everybody. I'm Dr. Enmin Wang from the Huashan Hospital. Today, I presentation is the Cyberknife radiosurgery for the brainstem lesion. We know the gamma knife, but the Cyberknife invented by the a neurosurgeon, Dr. John Adler from the Stanford. In most situations, Cyberknife is for the cerebral tumor, sometimes for the body tumor. Today, I to share our experience in the Cyberknife radiosurgery for the brainstem lesion. But this is a large topic. You know, the brain lesion, brainstem is incredibly complex. It contains the nuclei, pathway, and the structure. Brainstem has a vital function, including the breathing, the control, the blood pressure, and the heart rate, swelling, as well as the consciousness. It's a very sensitive organ to irradiation. Cyberknife treatment of the brainstem lesion must be given special attention. Patients with a brainstem lesion can be wide spectrum of disease, but for Cyberknife, brainstem lesion often with metastasis, brainstem, AVM, cavernous malformation, and low-grade glioma in the brainstem. You know, before the invention of the Cyberknife, we used gamma knife for the radiosurgery. In this presentation, I will show Huashan experience in the treatment of the brainstem metastasis, brainstem AVM, low-grade glioma, and the cavernous malformation. In our hospital, from the 1993, we had the gamma knife, but now we have treated more than 50,000 patients with the gamma knife. From the 2007, we had the Cyberknife. Most patients are treated with central nervous system disease. Some is for the body tumor. Cyberknife radiosurgery has an advantage over the single stereotactic radiosurgery. I know it make a bad use of the precision of the stereotactic radiosurgery. it make better use of the multifraction. Multifraction reduce the side effect to the normal tissue and the round lesion. We have introduced two techniques for Cyberknife. Dose sculpting technique in dose planning, which allow us to deliver higher written dose within the tumor and to avoid the high dose to the critical structure. Stage the Cyberknife treatment based on the gamma knife experience for the lesion next to the critical structure. You know, the stereotactic research usually use a single fraction, but now we use the multi-fraction stereotactic radiosurgery. You know, for the large tumor, for the gamma knife, we use the staged gamma knife. From the gamma knife experience, we use a Cyberknife for the staged Cyberknife for the tumor in the brain lesion. First, I introduced the dose sculpture technique. This is a recurrent the mini tumor in the clavers. You know, the tumor compresses the brainstem. We treated the tumor with a high dose in the tumor base, but avoid the high dose to the brainstem. 5 years later, after the Cyberknife, the tumor decreased and the compression of the brainstem have improved. This is the same 5 years post Cyberknife, the tumor remained stable. We have followed this patient for 11 years, but the 10 years, the tumor invaded the basement of the skull and treated with the Cyberknife again. This is we introduce the staged multi-fraction Cyberknife. This is a patient with C2 to 4 level ependymoma. The patient had operation and radiation therapy. 1 year after operation and radiotherapy, the tumor spread to the brainstem like this. Then we used the staged Cyberknife, treated the tumor in the brainstem. 18 months after Cyberknife, this tumor decreasing size, maybe relapse, a small relapse. We treated with the third Cyberknife. This is 3 years after the Cyberknife, the tumor remained stable. The patient do not have the deterioration in the symptom. So our experience come from the gamma knife. This is the brainstem metastasis we treated with the gamma knife. In the first stage, we prescribed the 12 gray for this tumor, and 2 weeks later, the second gamma knife, the 10 gray for the tumor. That is we call the stage gamma knife. 6 months, tumor decrease in size. The patient improve their neurological deficit, and 1 year to 1 month, the brain metastasis kept stable, and the patient had a high quality of life. But 1 year to 7 months after the gamma knife, the tumor relapsed. The third gamma knife and combined with bevacizumab. For this patient, the overall survival was 2 years. So with the experience with the gamma knife, so we use Cyberknife for the staged Cyberknife treatment. Cyberknife for the brainstem metastasis. You know, the brain metastasis represent 4% to 7% of all secondary intracranial tumor. SRS is an effective treatment for the brainstem metastasis. The purpose is to achieve the local control of the brainstem metastasis and improve or keep the stable immunological deficit. There are 5 studies and a symptom review about the Cyberknife for the brainstem metastasis. You know, the different centers use a different fraction. So we use the BED, the biological equivalent dose, to compare the written dose. For the prescription dose is 43.1 BED gray. Isotoline is the 80%. The maximum dose is is 23.3, but the for the maximum the BD is 61.1 BD grade. Some use 1 fraction, some use 5 fraction. Nakamura reported 20 patients with 26 lesions of the brainstem metastasis treated with a Cyberknife. The median survival was 11.5 months. The treatment scheme was 3 fraction times 3 fraction or 5 fraction. The 6 to the 12 months local control of the tumor rate was 100% and 29% and 90% respectively. But the 6 and 12 months overall survival was 76% and 53% respectively. The long overall survival was associated with GPA more than 2. Liu reported 54 patients with brainstem metastasis. The median overall survival was 5 months. KPS, GPA class, and extracranial disease control predicted the overall survival. Chen reported system review, the effect and safety of the stereotactic radiosurgery for brainstem metastasis. Patient with a brainstem metastasis that was treated with the median dose of the 16 Curie in 1 fraction. They use the gamma knife. The median 1 fraction. They use a summary. They use 16 Curie in 1 fraction. The median 1 fraction. Usually the range is 1 to 13 fraction. Local control at 1 year was 60% across 31 study. The objective response rate was 59%. The symptom improve was 55%. The 1 year overall survival was 33%, and the 2 years overall survival was 13%. The death from the brainstem metastasis progression after stereotactic radiosurgery was rare. It was 2.7%. That means the most deaths is from the disease original disease progression. So the author found that a single session exercise to the margin dose of the 15 to 18 Curie for the brainstem metastasis smaller than 1 cubic centimeter was associated with a higher local control, ORR, and symptomatic improvement, and the lower risk of toxic, effective, and death from the brainstem metastasis. Neurological death rate in patients with the brainstem metastasis was 24%, which was equivalent to the neurological death rate in the patient with the brain metastasis. The rate of the treatment-related grade 3 to 5 toxic effective was 2.4%. So I will introduce our experience in Cyberknife. Multi-fraction Cyberknife may make it possible to reduce the frequency of the adverse event while maintaining the local control rate in the brainstem radiation therapy. How to balance between the efficacy and the safety of the brainstem is very important. Our purpose is to improve or to keep the stable in the neurological deficit and the local control of the brainstem metastasis. More than 50 patients with the brainstem metastasis treated using the multi-fraction Cyberknife in our center. Our prescribed dose is the 39.4 Curie to the 48 Curie in BD, a different fraction. We usually use 7.5 Curie times the 3 fraction. Sometimes use 8.5 Curie times the 3 fraction. For the large tumor, we use the 5 Curie times the 4 fraction, 5 Curie times 5 fraction. If tumor located in the midbrain, the bone, we deliver a little higher dose. If the tumor located in the medullary area. We prescribe the lower dose. Our tumor local control was 97% of the 6 months. The median overall survival was 11 months. When we prescribe the lower dose, we use the lower isodose line to deliver higher dose within the tumor. The higher dose, the long tumor control, the side effect was lower and keep the stable. The neurological deficit keep it stable or improved in 80% of the patient. I showed some of the cases. This is the patient with breast cancer, had the brainstem metastasis. We use 8 gray times 3 fraction. This is the treatment planning. 3 months post the Cyberknife, the tumor decrease in size. But 6 months, a new brain metastasis appear and a second Cyberknife. For this patient, the overall survival is 13 months. This is another patient with lung cancer. He had the brainstem metastasis. We used 7 gray times 4 fraction. The BD was 47 gray. 1 year, the tumor decreased. This is 1 year and 3 months, the tumor decreased in size. 20 months, the tumor keeps stable. For this patient, the overall survival was 2 years. Sorry. This is a patient with the brainstem metastasis from the lung cancer. We use 3 fraction. Every fraction is 7.5 gray. 7 months post Cyberknife, the patient had a deterioration in their neurological deficits. This is I think this is brain damage. 15 months. This is a radiation, the damage, like this. And 22 months, the patient had the left meningeal metastasis. For this is a large tumor. He's near the brainstem, so we use more fraction, 5 gray times 6 fraction. We use a higher eresin dose to treat this large tumor. And 6 months, tumor disappeared. And 3 years post Cyberknife, a new tumor appeared in here. We treated with Cyberknife again. This is 1.5 months post the second Cyberknife. The tumor disappeared, almost disappeared. For this patient, the overall survival was 3 years and 5 months. This is another, the patient with the lung cancer had the brainstem metastasis treated with the Cyberknife. 3 months, the no brain edema, the neurological symptom improved. We use dose sculpting for this large tumor, near the brainstem. You know the tumor compressed the brainstem. This is dose planning for this area. There is a lower dose. The isotope line very compact. So 3 months, this tumor disappeared, but in the left cerebellum a new tumor appeared. We treated again. Next, I will talk the gamma knife for the brain AVM, brainstem AVM. Brainstem AVM harbor a higher morbidity and mortality. Treatment modality are embolization, SIS, operation, observation, or combined treatment strategy. SIS has an important role in the treatment of the brainstem AVM. Cohen-Ingvar report the 205 patients in the multi-center study. Overall obliteration was reported in 65%, 0.4% at the median follow-up after 69 months. The active rate of obliteration at 3, 5, 7, and 10 years after SIS was 43%, 43.3%, 62.3%, and 73% and 89.8% respectively. Patients treated with the margin dose more than 20 gray was more likely to achieve the obliteration. But for this higher resin dose, there are more side effects. Post-SIS hemorrhage occur in 8.8%. Radiation-induced complication was radiologically evident in the 35.6%. So for the brainstem is very sensitive to the radiation. So the neurological evidence is quite high. The symptomatic is in the neurological complication was 14.6%, and the permanent neurological complication is 14.6%. However, unlike with the IC in the other brain location, brainstem AVM patient that developed the initial symptomatic radiation-induced complication had long and not transient symptom. That means if the patient developed the radiation-induced complication, that will be the permanent. So Kano reported 67 patients with the brainstem AVM. The active rate of the total obliteration was 41%, 70%, 70%, and 76% at the 3, 4, 5, and 10 years respectively. In 2021 reported 26, the brainstem AVM obliteration was 42%. Higher margin dose, more than 14 gray, was associated with a higher obliteration. Cyberknife, Cyberknife treat less the brain AVM. Young reported SIs for the brainstem AVM. Some brainstem AVM was treated using the gamma knife or Cyberknife. The margin dose was 16 gray. The obliteration rate was 43.8%. There are no study on the Cyberknife for the brainstem AVM. Washington Hospital had treated 7 patients with the brainstem AVM. 4 of them was obliteration, 3 decreasing size, no bleeding. 1 patient developed a neurological deficit. Multi-fraction Cyberknife is effective and safe for the brainstem AVM. The prescription dose was 19.5 gray to the 22.5 gray in 3 fraction, or 10.5 gray multiple times 2 fraction. I show some of the cases. This is the patient with the AVM in the medulla and the C1 cervical spinal cord. This is a DSA. Ablation combined with the Cyberknife. We used 3 fraction. Every fraction is rated 6 gray. This is treatment planning. 8 years, the follow-up 8 years after Cyberknife and embolization, AVM decreased. The patient have no the brain edema. The neurological deficit can improve. This is another diencephalon and the midbrain AVM. This is the treatment planning. The 14 months post Cyberknife, AVM decrease in size, no edema, and no new neurological deficit developed. This is another brain stem AVM treated with Cyberknife. Dose planning. 3 years post the Cyberknife, the DSA show AVM obliterated. This is the MR. This is another patient with the thalamus and midbrain AVM. The first, she had embolization, then Cyberknife treatment for this patient. 2.5 years after the Cyberknife, the MR showed him almost obliterated, but the patient developed worsening in walking and speech. There is the damage in the midbrain and thalamus. So the next I will introduce the Cyberknife for the brainstem glioma. There is one paper reporting the Cyberknife for the brainstem glioma. There are more papers reporting the gamma knife for low-grade brainstem glioma. For well-circumscribed low-grade brainstem glioma, SIS or fractionated SIS can be adjuvant or definitive treatment modality. John reported the Cyberknife for adult brainstem glioma, 10 years experience. The median follow-up time was 44.5 months. The patient with the brainstem glioma had the median overall survival of the 19 months. Gaglinde in 2021 reported the gamma knife radiosurgery for the primary treatment for the low-grade brainstem glioma. Systematic review and the meta-analysis of the current evidence and predictive factor. I show some of the functional appearance in the brainstem glioma. We use the conventional radiation therapy for the 26 degree in the 13 fraction, or the 27 degree in 15 fraction. Then we use the Cyberknife was used as the stereotactic boosting for the brainstem glioma. The total BD was 60 to the 61 degree, but within the tumor, the BD more than 60 degree. The treatment strategy is to decrease the normal brain dose and to increase the dose within the tumor. I show some of the cases. This is the brainstem glioma. The patient had conventional radiation therapy. Then we use a Cyberknife to boost in the tumor. 6 months and 18 months. There is a residual tumor and the second Cyberknife. This is a 3-year. The tumor remained stable. And this is a medullary the glioma. After the operation, this is astrocytoma grade 1. The post-operation, the tumor residue here, we treated with the Cyberknife. 2 years post the Cyberknife, the second the tumor reduced in size, and we treated with the second Cyberknife. And this is 4.5 years. This is 12 years post the Cyberknife. The tumor almost disappeared, but the patient have improvement in their neurological deficit. Brainstem Cyberknife for the brainstem cavernous malformation. You know, the brainstem cavernous malformation has a higher annual incidence rate of the hemorrhage than the non-brainstem cavernous malformation per year per person. Park reported the gamma knife radiosurgery for the brainstem cavernous malformation with a 13 grade. This is the low prescription dose to compare with the other also. The calculated annual hemorrhage rate was 40% pre the gamma knife, but 3.3% at the 2 year after the gamma knife, and 1.48% at the 5 year after the gamma knife. That means the gamma knife treatment reduced the hemorrhage for the cavernous malformation in the brainstem. 45 patients, symptomatic radiation-induced complication developed in only 1 patient. No patient had died at the last follow-up. We treated 5 patients with a symptomatic brainstem cavernous malformation using the Cyberknife. 1 of the 5 patients remained stable. 4 of them have improved the neurological deficit. I show the cases. This is a cavernous malformation in the midbrain. These are very difficult for the operation. After the Cyberknife, the patient do not have the bleeding. The 4 years post Cyberknife, the cavernous malformation decreased a little in size. This is 8 years post Cyberknife. Adverse radiation effects are on the brainstem. Quantitative analysis of the normal tissue effect in the clinic indicated that the risk for adverse event increased when the single fraction maximum brainstem dose exceed 12.5 gray. But in our clinical use, in our clinical application, we use, I think the brainstem can tolerate more than 12.5 gray. Some other panels have estimated that the brainstem can tolerate the maximum dose of the 15 gray delivered in one single fraction. The AAPM task group 101 and the UK consensus on the normal tissue dose constraint for the stereotactic radiotherapy both conclude that the brainstem could tolerate a maximum dose of the 14 gray. This report the clinical and radiographical adverse event after the gamma knife radiosurgery for brainstem lesion. The 5 of the brainstem received the dose is associated with the clinical adverse event. Increased to the dose, the 5% to the brainstem increase the risk of the developing the clinical complication. What is the maximum dose for the brainstem in multi-fraction Cyberknife radiosurgery? But there is no answer. Middle brain and the pone usually tolerate a maximum dose of the 13 gray in one fraction for benign lesion. The medulla is 12.5 gray in one fraction. Then we calculate the BD for multi-fraction. There is no consensus for the tolerance for the brainstem in Cyberknife. We use the gamma knife tolerance dose and to calculate to the multi-fraction. For malignant lesion, the maximum dose for the brainstem was the 15 gray in one fraction. Our conclusion: brainstem lesions are located in the surgical accessible area. It is extremely difficult to perform surgery for the lesion in and around the brainstem without complication. Cyberknife radiosurgery is one of the most innovative conformal technique, has focused on the decreasing morbidity by limiting the radiation delivery to the surrounding tissue. Cyberknife has gained an increasingly important role in the treatment of the brainstem lesion, the brainstem metastasis, brainstem AVM, and the local brainstem glioma and the brainstem cavernous malformation. Thank you for your attention. Thank you all.
Thank you, Professor Min. That was just an amazing talk covering all those aspects and something that we as neurosurgeons are not very familiar with. There's a lot of misconception across the world on the use of radiosurgery and particularly Cyberknife. So this was a pretty enlightening lecture. And this is not coming from someone who has done like few cases. I think you have done more than 10,000 cases on Cyberknife. This is just an amazing number. So I just want to have the audience know about it, that, when Professor Inman speaks, it's not, that they have done 10 cases or 15 cases. There's an enormous amount of experience behind. So as I mentioned that the neurosurgeons in general are not very well versed with these things. would you, for some audience, and I'm doing at the risk of offending some of the very sophisticated and well-knowledge audience also, would you just talk about the basic differences of the Cyberknife and the Gamma knife, and the ability to do hyperfractionation and fractionation in Cyberknife versus the Gamma knife? That would, because the audience, as I understand, includes a lot of trainees as well. Thank you.
Okay, the Gamma knife usually use a single fraction, but from our experience, multi-fraction, lower dose Cyberknife reduce the brain edema after the treatment. The Gamma knife have the Lexel Perfection Gamma knife, but now we have the Icon Gamma knife. Icon Gamma knife can treat the tumor with the multi-fraction. So from the Gamma knife to the Cyberknife, from the single fraction to the multi-fraction, the treatment adverse event was reduced. For the single fraction, we usually rated the higher rating dose. The higher dose usually increase the brain edema, increase the adverse event. But now the radiosurgery is not the single stereotactic radiosurgery. Maybe one fraction, maybe 5 fraction, maybe more than 5 fraction. For the complicated case in the some area like the brainstem, we usually use more than 3 fraction. We use a 2-stage. That's to reduce the brain edema. But the tumor control has improved. The neurological deficit have improved. So I think the difference is because the Cyberknife do not need the frame, so the patient easily to accept this multi-fraction Cyberknife. But for the small tumor, especially for the benign small tumor like the acoustic neuroma or the mini tumor, I think the single fraction stereotactic radiosurgery like a Gamma knife have the same result as the Cyberknife. But Gamma knife have the very good selectivity and the conformality. But for Cyberknife, I think the conformality and the selectivity is inferior to the Gamma knife. The Gamma knife is designed by the neurosurgeon is very simple to the dose planning, but for Cyberknife is very complicated. We use the medical physics to help us to do the dose planning, but it's very very complicated.
Great, thank you. That's a good understanding. And as I understand that in the Gamma knife, you have to put those frame on, the pens and everything.
Yes.
And perfectionism is a problem. And in the Cyberknife, you just put a mask. And that mask can be taken off and reused again. So that does the trick for a Cyberknife. Now, there were a lot of other Linux-based systems, and like Xknife and Novalis and things like that. What has happened to them? Do these results apply to them? Because there are still some parts of the world where those are being used.
I know for the other the Linux-based stereotactic radiosurgery, the accuracy and the dose planning is not quite good as the Cyberknife, not quite good as the Gamma knife, because around the lesion, the normal tissue receives more dose, then gamma knife, then Cyberknife. This is our opinion.
Right. Thank you. Is there any more question from the audience, Professor? Yeah, go ahead.
There was one, but that was already answered well by Professor
I
Monangan.
have tons of questions. That. Thank you very much. I can. So the other thing that I wanted to ask you, Professor Edmund, was that when we neurosurgeons do a surgery, there's a cavity that forms over there, which is a dynamic cavity, and that keeps on changing its shape over time. And when we are applying radiosurgery, whether it's a gamma knife or Cyberknife, the margins and all those are done in one time frame. And if you want to do hyperfractionation, you will be doing it over time. Do you consider that there might be a shift? The cavity might have changed. The margins that you want to do has changed or not?
For some tumor is very sensitive to the radiation. Maybe the tumor margin maybe changed during your treatment. But in our center, we treat the patient every day. If the patient use 3 fraction, we treat the patient every day. But during the 3 days, I think the tumor margin changed little.
Right, great, thank you. And what about the hyperfractionation where you're doing 2 fractions within a day?
2 fractions in one day?
Yes.
No, we never use 2 fractions in one day. In our center, we treated the patient every day. 2 fraction today, tomorrow. But for the we treat some of the very difficult cases for the metastasis in the spinal cord. Spinal cord. We usually with the 3 fraction, then 1 or 2 months, another 3 fraction, use a stage the Cyberknife, the tumor decrease the neurological deficit improved. We use this kind of the strategy for the very difficult cases. The multiple fraction stage the Cyberknife.
Right. And any experience with the trigeminal neuralgia with the multiple fractions?
No, we only treat one patient with trigeminal neuralgia. I know the Cyberknife have the some for the localization. The Cyberknife tracking the skull, the bone, skull bone. But for the gamma knife, they use the frame, use the MR localization. We can see the trigeminal nerve clearly. But for Cyberknife, they tracking the skull bone. We use the CT. Although we feel the CT and the MR, there are some of the, I think there are some of the error. So we, for the trigeminal neuralgia, we refer the patient to our gamma knife center.
Okay, great. Thank you. Professor Raja, please advise if there's any question or...
There are none. You may conclude by giving your expert remarks.
So well, I mean, in front of Professor Edmund, there is no expert remark, okay? I mean, with the experience that he brings to these conferences and to his talks, it's just amazing. So no expert remark except for that it was an amazing talk, and thank you for just giving us a very short brief of all that you have seen and all that you have experienced, and presenting it in a scientific way, in an evidence-based manner. It definitely will be a guiding light for a lot of us. And I'm sure that you are working on a book on that one. If I remember if I remember correctly, you were going to write something on that a while ago. Somebody told me that that all the experience about the radiosurgery, you were planning to write that. So let's see when that book comes out.
Okay. Thank you.
Well, thank you very much, Professor Enmin Wong and Professor Sai Dattarinam, for that wonderful session. Great experience to hear and learn from such a huge experience of Professor Enmin Wong. So I'll conclude this officially on behalf of the Education Committee of the ACNS and the President, Professor Yuko Kato. I would like to thank both the speakers of today, Professor Krish Sridhar and Professor Enmin Wong, as well as the chairs, Professor Imad Kanan and Professor Sai Dattarinam, for the time and support for the ACNS webinars. And I'm also extremely grateful to Professor Shubin for broadcasting this on the WeChat channel. And as I mentioned earlier, we have around 330 people who have joined us live from across the globe. Until we all meet on the 21st of December, it is bye-bye from all of us. Thank you very much for joining.